Today we get to hear from Tanya. I'm so excited to welcome her. And before we really jump in, let's just all breathe together because it's so important to feel grounded, feel connected, and not feel scattered. So, hi, good morning on my side of the world, good evening in your side of the world, and welcome to our next broadcast.
Let's see if Tanya can join us. Welcome.
Hi, Augustine.
Hi, my friend. How are you?
I'm good. Hi, everybody.
I know
I
it's
see
great.
people joining. It's so nice.
It is so nice. You look beautiful. How is your spirit?
Well, it's good. And it's really very, very, very crazy here right now. And there's a lot to talk about. But I will tell you that it is terrific to have the spotlight being shown on birth and on birthing people and how the system is affecting these people.
Yeah.
So I think for that reason, we've gotten really lucky in that we're getting some attention,
Yeah.
and I'm glad for that.
Yeah, me too. Well, so where do you want to start? Because I want to cover all the topics that you have to share. What feels up for you right now?
I mean, I can just kind of tell you
Yeah, tell us
what
what's going on.
happened. Yeah,
Yeah.
I'll just tell you what happened.
Okay.
So here in New York, so if you're not tuning in from New York, here in New York City, we have a very vibrant, wonderful home birth midwives community. There are about 20 of us, and it's great. We have a great little organization. We all work together. We have a very thriving doula community. A million doulas here, and as you can imagine, a bajillion people birthing in
Yeah.
many hospitals and less than 1% at home.
Yeah.
So we're very lucky here. Home birth is covered by insurance. It's great.
Yeah.
So what happened basically was that as soon as COVID-19 started coming up and kind of people weren't really worried about it, and as soon as one of the hospitals said that the doulas couldn't come in, the home birth midwives' phones started ringing. And they started ringing and ringing and ringing, and they rang with people saying, "Hi, because of COVID-19, I'm wondering if you're available for a home birth."
Yeah.
So yeah, like people calling and saying, like, can I have an epidural at home? Like,
Yeah.
can I? Yeah. So what we did collectively was we came together as home birth midwives here, saying, like, what are we going to do? Like, doulas were text messaging us and pinging us on Facebook, and one doula called one of the home birth midwives while somebody was pushing and said, like, she won't go to the hospital. Can you just come here? And like, all of this, and this is not ideal. And I know that midwives, like, we will go the distance for people, but when every single person who's calling you is desperate, it's a
different.
total reset button. And
Yeah.
so collectively we came together and wrote a statement. So my midwife partner Rovina actually did the writing, but we all collectively talked about the ideas
Signed it.
together.
Yeah.
And if you haven't seen it, it's at nyhomebirth.com. There's a statement on COVID-19, and it just basically says, like, we can't save you. Like, we're full. We are people who have wanted home births all along, are with us, and we don't have enough midwives, and we don't have enough resources, and essentially that people need to take their energies and put it back on the systems that they entrusted to their care in the first place. So that was sort of kind of came out. And then a few days later, one major hospital system made a policy that partners could no longer come in. So people were going into the hospital to birth alone. And then the second biggest, so there are two major hospital systems, New York Presbyterian and Mount Sinai. Tons of people birth there. At both of those places, people are birthing alone. Fortunately, Mount Sinai has midwives, a few. So those people will have their midwives with them. But generally speaking, I think we got 20 inquiries yesterday.
Wow, that's so much. That's so much for you to handle too. And the feeling of having to say no. That's really intense.
It is intense, and I feel like the situation here keeps getting worse and worse. So
Yeah.
it's like every day we have to renew our commitment to our clients and our commitments to ourselves and to public health and to each other. A lot of the midwives here in town have said, I'll take what I can take, but I absolutely will not take more than that. And the reason why is because this thing is spreading like crazy,
Yeah.
and we need to be well. I mean, you know, midwifery doesn't hurt us enough. Like now we need to
Yeah.
like get COVID-19 on top of it.
Yeah.
So it's a no,
Yeah.
it's for our own preservation. And I think now it's like, I was just saying to my group of, doulas and people that I know in Manhattan Birth that like I'm starting to think that birthing people, and specifically women, can be convinced of anything. Like, we've convinced
Yeah.
them that they need to go to we've convinced healthy low risk people that they need to go to the high risk hospital where the COVID-19 patients are going to have their babies.
Yeah.
And what's no, somebody's I see a question here. Somebody said they think it's only Mount Sinai West. No, it's all of Mount Sinai and all of New York Presbyterian, and that is confirmed. So call your doctor. And what has happened is we've convinced people that they can't birth there,
Yeah.
can't birth anywhere but there. And so what's happened is that there's no other alternative for people. It's definitely like there's no birth centers, there's no maternity hospitals, there's no place that says sick people don't come here, only birthing people come here.
That's right. Yep. And this has been a problem for decades in the US, but somehow people have not acknowledged that problem. And I think you're right. This is one of the strange silver linings to come out of this situation, is that actually we suddenly have a focus on an issue that has existed for a long time.
Yeah, and I think that,
Yeah.
when this is all sort of said and done, there's going to be a reckoning. And I do
Yeah.
think that in 5 or 6 years, we will see a swell of midwives come out of this.
Yeah.
We need more midwives. If you are a doula watching this and you think you're getting the call, we need you. Please come be a midwife.
Yeah, totally.
Yeah.
But take the training first.
Yeah, of course. Yeah.
The thing I've been
go
hearing
for it. Yeah, is what I'm
around the
saying.
country is that now women, because they're being told they can't take their doulas, they're just staying home with their doulas.
Yes. So
around
that's
the
definitely
country.
what happened already to one of the home birth midwives, is that she was
Yeah.
called by a doula. Obviously, we're close with the doula community. And the doula said, this client is pushing, I think I see head, can you come?
Yeah.
And so that's what people are doing. They're either staying home with their doulas, some people, many people just saying like they're just going to do it unassisted, just them and, their partner for a first baby.
Yeah. It's really not a good idea. If you were convicted of that idea before this pandemic, certainly I think we all should have body autonomy and the choice to do what we do with our body. But if you're choosing to stay home as a reaction to fear, that is a very poor decision-making process, I think. And
and it's not safe even if you've got a midwife with you. That like, what makes you a candidate for home birth? Oh, I'm really healthy and I'm also scared.
Yeah.
So take me as a client. It's like, no.
No.
That's
well,
not
so this is because New York is really the epicenter in the US right now, and you are in Manhattan, kind of the real epicenter. You are really poised more than most to make this critical thinking analysis of who do I take. And I've been talking about this in theory with a number of midwives on the program, but you're the first one to really have that tested with 20 calls today alone. Can you tell us more about how you're going about making those decisions? What questions, because probably you're not meeting with them in person, so these are telemedicine conversations anyway. What are you doing to ask the questions to get the risk status to make the decision?
Well, I will tell you that as a community, we have talked about this extensively. We've had several, virtual meetings with all of the home birth midwives here in town. We all support each other. It may seem that someone is in solo practice, but we are truly never alone here. It's one of the beautiful things about New York. Yeah. So I will tell you that my practice was basically full when this happened. We were already maxed. And, we can decide how many people per month we take. And we probably could have squeezed in a couple more, but we had already decided that, we didn't want to take that many, and we were exhausted, and we felt like we were never off. So my partner and I made a blanket decision that for the next several weeks, we're not taking any new clients, even who are due in November. Like, we're not taking anybody right now. So we're just dealing with who we have. That being said, I'm also a childbirth educator, so I'm assisting my students to get to a place where they feel comfortable, and many of them have wanted to go to home birth. I think probably these are people, they took my 8-week childbirth class. These are people who probably would have had their next baby at home. They were already with a hospital midwifery practice, and they were pretty close anyway, and this pushed them over the edge. But what has happened is that so many people have called. Basically, you kind of have to know somebody or have the right wording to even get in the door. And it needs to be, about the philosophy of what you believe about your body, what you believe about your autonomy, what you believe about birth and your family, and what it is that you want. And yes, you happen to be low risk, and you have to pay for it. Like, these things have to happen. So I think what's happening is that people who, the midwives who are sensing any sense of fear, and you can see it in the emails. There are some midwives that get calls on their cell phone. We have somebody that takes those calls for us, but she can smell it a mile away. It's like, people don't even know what home birth is. They've done no research. They say,
can I have an epidural at my home birth? One of those. And
I think
you don't understand what you're choosing.
They don't know what they're choosing, and it goes along with the whole, I see on social media people discussing I would probably just go home and have my baby, except for with my last baby, I hemorrhaged and I almost died, so I could never have my baby at home. And it's like, okay, well, you already don't know that what I would do for you is exactly what they did for you.
There's so much misinformation. Well, and what we're seeing obviously highlighted in the maternity care world is actually exists all over the US healthcare system. And it's that the public healthcare system is not substantial. If you don't have the means, you really can't get care. And part of me says, I'm so glad to hear you and others say, I value myself, I matter, I need to be paid, my boundaries are such. I'm so glad to hear that from the sustainability of you in your life. But I'm so devastated from a public health perspective, because it means not just today, but into the future in the United States, that people without means cannot get care. And now more than ever, that's becoming so salient and so obvious. It shows us how truly broken our healthcare system is. Switching gears now from your practice, can you tell us more about what you know that's happening on the ground in Manhattan or in New York City around the actual COVID cases? Are there certain hospitals or parts of hospitals that are roped off? Are there more testing sites? What do you know that's happening there?
It's really slow. That I can tell you. It's slow. I mean, there are certain hospitals where people can get tested more easily and certain hospitals where they can't. And you can probably guess what they are. So that means the private hospitals, for example, if we look at New York Presbyterian, COVID or not COVID, anybody who is going to birth there is tested for COVID as they arrive. Whereas on the other hand, in the public hospitals, it's like a war zone. They don't have the PPE that they need in the COVID. They're intubating people in the emergency rooms because they don't have enough spaces to put people. They certainly are not testing anybody on labor and delivery. They don't have isolation rooms on labor and delivery. So, we had a couple of patients who needed to be who needed to be tested, one that we were quite certain was possibly going to have it. It turned out she was negative, but she went to a private hospital. And they tested her immediately and put her in isolation, and she had results within 8 hours.
Wow.
With the means. Whereas, we had another client who was sort of further away from the epicenter, didn't have as many resources, works more in the public sector, and she tried to go to a drive-through. They needed a prescription, so I wrote the prescription.
Oh my God.
Gave her that. And she had that test last Wednesday and still doesn't have results. She's feeling better. But it can take a very, very long time if you even get tested. And what they're kind of saying now is that if your symptoms are relatively mild and you don't need to be admitted and you don't need to be intubated, then they're saying they're not testing people because it doesn't change their treatment. They're just going to send them home anyway. So we, in fact, don't even know how many cases there are.
Yeah.
Whatever numbers you are seeing, it is way more than that. That's of the tests that they've done.
Right.
So you really, what's happening here on the ground is like people, like we're telling our clients, do not go anywhere.
Yeah.
Stay home. Go out on your balcony. Don't go to the grocery store. Call delivery. Don't get near anybody, especially our people who are due, because if they are positive, the CDC says that they're high risk and that they have to be separated from their babies for 14 days.
Oh God, that's a whole nother thing.
I can't even. Yeah.
I can't
We're all sitting, the home birth midwives are all sitting and saying, this is what the CDC said, that somebody who has COVID in labor is too high risk to be at home. And like, what do we do? Send them to the place where no one can go with them? Like, no. So the good news is that Mayor de Blasio said today that all of the public hospitals, the city hospitals, which of course are run by the midwifery service and are the places where we transfer people if we need to, they will remain allowing one person there. So most like very fancy people of means are not going to go to these hospitals, but of course they're wonderful places to have a baby, and that's great. But as far as COVID goes, those places have very few resources. And yeah, I mean, it's really bad. They're saying it's like a war zone. They're running out of ventilators. Governor Cuomo today said that we need 30,000 ventilators in New York State. We need 30,000 more ventilators than we thought we needed. And the federal government sent 400.
It's just mind-boggling. And we're just at the beginning of the wave, I think. Us up to January 21st in Wuhan kind of modeling. I mean, like we're right at the beginning.
Yeah.
Oh, gosh. Oh, my heart is just so full for you and for all of the health workers right there in the center. So, given that this is going to get worse, you can say no if you don't want to, but I'm wondering if you'd be willing to talk through if you have a strategy for when you have an obviously positive client, or you get called to a labor with someone coughing in the background, or what are you going to do when this gets worse? And this is not even taking random strangers on the street. This is just your clients. Yeah, this is just your actual clients. What are your plans?
So I should mention, just to kind of like let people understand like the situation here, is that many midwife friends of mine who work in the hospitals are sick. Yeah. Like they have COVID-19. So this is so real, which is a big reason why we're not taking strangers off the street. So this is what we've been discussing right now within our community. As far as we know, there has not been a COVID positive laboring home birth client at this point. That's as far as we know. And what we've been telling our clients is that the party line is that if you have COVID-19 diagnosed positive and then you go into labor, that you need to transfer. But the reality is that it's going to be a case-by-case basis. And what we have done is procured some PPE that we're saving for those borderline cases where you've got a situation with someone who is declining going to the hospital, who will not go. And we are concerned for our own safety. So somebody who obviously is not someone who needs to be intubated right now. I mean, obviously they
Right.
can decline. You know, if somebody needs
Right.
to be intubated, they can't breathe. They're going to want to go. So, you know,
Good
so
distinction. I like that.
yeah.
Yes.
So what we've decided, here are all the things that we've sort of put in place. But in a case like that, we do have N95 masks. Every midwife has some that they've gotten from their clients who had them in their houses, or, you know, they had one from nursing school that they kept, or from midwifery school that they had when they did their hospital rotation and they kept it. So they have a few of those things. Here's what my practice has. We have a couple of suits.
Yeah.
We have a few N95 masks that fit us. We have gloves. And our plan would be that if anybody had a cough or was not diagnosed or was declining to go or something like that, that we would suit up, and that's what we would do for them. I don't think there's going to be a lot of people like that, because all the home birth midwives are like cracking down and saying, you cannot leave. If we think you're sick, you can't have a home birth. So, so that's been really, really helping. I think right now we've been reading a lot of articles about transmission, about what we need to know. And it seems that if someone is asymptomatic and has been home for the last 2 weeks and believes that they haven't been exposed, then a surgical mask is totally reasonable. So surgical mask and gloves for everybody, for us and for our birth assistant, and not for the laboring person. Yeah. I think that expecting a laboring person to wear a mask I think that's probably not going to happen.
Yeah, it almost feels like a human rights violation. It's so crazy. Like,
yeah, I think it's happening in the hospitals.
I know it is. I know.
Not
To birth
N95
alone
masks, like surgical
with
masks.
suited, yeah, I know, but I mean, to birth alone with suited strangers, having to cover yourself, and I can't even imagine right now. I can't even imagine.
For first baby especially. I mean, it's terrifying. It's terrifying. So that is, I think, what is basically going to happen. And this is unfolding daily. Like, we're all talking to each other daily. I'm getting text messages from the midwives that I know who live in the hospital, who work in the hospital, who say, you know, I'm homesick. What are you guys doing to keep yourselves safe? Tell me that you have PPE. What are you doing? You know, so I mean, we're fortunate in that we don't have to go in there and serve the public. We get to pick. It's our hospital midwives that are the real heroes.
Yeah.
And we don't have enough of them. And so if you have
we've been short for decades, but now it's really obvious. Yeah.
If we have a hospital midwife, they're gonna sit in there and hold your hand for you. That they'll do, you know? But it's very, very tricky. And so the other thing that we're doing is, my partner and I are not seeing each other. We have separated from each other, knowing that if one of us gets sick, the other one will not. If I catch a baby, I am also doing the postpartum for that person. We've pushed the postpartum out. We're doing a little bit more virtual for a couple of days, and then going to see them on day 4 to do the heel prick test. And just sort of working it that way, keeping everything much more contained. We're only seeing people in person if we absolutely have to prenatally. So that is, we're basically just on the computer all day, having people get their own blood pressure cuffs, teaching them how to measure their fundus, which is actually really fun.
It is fun,
and you know, monitoring fetal movements and that kind of thing.
Yeah. Well, we just had a viewer ask how you're changing your prenatal care plan, and you said just almost not at all. Do you have any structure, any ideas for people?
Yeah. So, and I just want to say, like, if anybody is practicing in a place that is not New York City, that you think this is not coming to you, people are fleeing this town to birth in their hometowns. It's coming. I'm just saying, it's coming.
Yeah.
So,
I just heard that there are Airbnbs in North Carolina that are renting for $10,000 a night from New York City folks fleeing the city.
Oh, yeah. I mean, anybody who has the means to leave will leave, and everybody else is going to stay here. And it's
overwhelm the hospital system.
And overwhelm the hospital system. So here's what we're doing. So If we have somebody who needs lab work, we will see them. But a lot of our routine screenings that we do in the first trimester, we're pushing off to do a little bit later. So that way we can do, if somebody desires to have an AFP, we would do everything at that visit. So maybe a 16-week visit where we would do all the first trimester labs and an AFP. We typically see people in our practice at about 12 weeks in person, or 10 weeks if they want NIPT drawn. But usually we just draw the NIPT. So in that case, like all of this, we would sort of package as one thing. If they wanted NIPT, we would do everything at around 12 weeks, and then a 28-week and a 36-week. And that's basically it, as long as everything is routinely going well. And if they, have any more issues or problems, of course, we can talk them through it. We can see them. We can send them for ultrasounds. We can do what we need to do. But the great thing about it is that for a moment, I think, and I should say, we're coming to the birth. We're doing one in-person postpartum, and we are doing no home visits. None. So what are we going to do? I'm going to go to somebody's apartment. They have a kitchen and a bedroom and a bathroom. Like, what do I need to know? It's going to be fine.
Once you've done a few home births, you kind of get the idea. Huh?
I mean, it's a home, So sometimes they have more than one bedroom. So
the equipment that you bring is what you need to know. So luckily, that's the same every time. Yeah.
So what we're doing is no home visits except for the birth and the one postpartum. We're not hugging any of our clients. The in-person visits that we do are limited to 10 minutes long, with the exception of the one postpartum visit that we do where we have to weigh the baby and do, all of that stuff. So what that means is I just had somebody come in for a GCT the other day. So she came in, I'm here in my home office. Typically people come in downstairs, my apartment, Augustine.
I do. I love your apartment.
Downstairs, and then they come. My office is your room. So they come upstairs, and they hang the coat. We offer them tea or water. They say hi to my family, and then they come upstairs. So we actually have an entrance to this apartment on the second floor, right next to the office. So people are leaving their coats and their shoes outside. They're coming straight in here, washing their hands, coming straight in here. And I always say we're doing it OB style. Like, are you alive? Let me measure you. Let me listen to the heartbeat.
Are you alive?
Bye.
I love you so much. Are you alive? Let me take your vitals. Goodbye.
It's going well. Okay. So then what we're doing is they leave and we meet with them on online. We're using Zoom right now, but we'll use whatever we need to use. And we just, sit down and focus just the way that you did. We sit down with them and lean in and say, hi, it's great to see you. And then
how are you?
We do this. And that actually feels really nice, is that like when the screen comes up and I see my clients, there's nobody's wet from the rain. Nobody's late. Nobody's the stupid subway. Like that's just totally removed. It's like we turn on the screen and there's a relief in connecting with another person, which we all desperately need right now. Yeah, we do. And we're assigning all of our clients to get 12 hugs a day, to do the math in their families and see how many hugs they need to get from the people around them so they can get those good feelings they need.
And you're doing beautiful virtual hugs, I'm sure. Your eyeballs make everybody feel better. They make me feel better.
Well, we're calling it eye hugging.
I love it.
Weird? Look. I'm eye hugging you.
I love it. It's totally, I was already feeling this from you. I was already intuiting this feeling. You're nailing it, my friend. Nailing it. I love it.
Is it creepy yet? How about now?
No. It's great. Oh, you're fantastic. Well, so I see how much you're taking care of your family by preventing transmission and taking care of your clients by eye hugging. But I want to know how you're taking care of you. Will you tell us about about your self-care or your rituals that help you feel grounded and able to keep doing all of this?
I sure will. So, I see friends on here. Hi guys.
Yeah.
So, oh, thanks, Natalie. One of my clients is on here. So, I first of all, I should just say that the ability to roll out of bed and be at work is wonderful. I mean,
Yeah.
one of the things that is so hard about being a midwife in New York City is trying to break through the mountain that is what is standing between you and the place you need to get.
Yeah.
And that is people and their problems and, everything that is standing in the way, traffic, parking, cops, like
Yeah.
lines, like all of these things. And so having that removed from my life and removed from my client's life and removed from my family's life
Yeah.
has been a beautiful way to
Yeah.
just, it's a bit of gift. It's been such a
Yeah. Yeah.
blessing in a way that just says, you guys slow down, New York, like
Yeah.
slow down and look at what's in front of you. So that has been really nice.
Yeah.
And the other thing that I have found very, very rewarding is the way that the midwives have really come together. I don't think I need to tell you about midwives and infighting.
Beautiful. I'm so happy to hear that. And I'm hearing this echoing across the globe, actually. And it's one of my most happiest things, too. Tell me more.
We just suddenly, everybody agreed. Like
Yeah.
nobody had any kind of issue with each other. Nobody had an issue with somebody's credential. Nobody had an issue with somebody's, practices, or this person does this, or this person does this, or did that, or did. It's just like, it's poof, it's gone. We have a singular goal. And it is the
Beautiful.
same goal. And, for me, like you and I have talked extensively about midwifery infighting and the way that we've been divided by the way that our healthcare in this country is structured, and how it harms the people that we want to help the most.
Yeah.
And that when we infight, we harm the very people that we are trying to help. And it has to do with, I think midwifery being primarily women and helping primarily women, and also the underserved. So women and the underserved, I would say, and us feeling less than, and that the only way that we can feel better is by putting other people down and keeping them small and bullying them and horizontal violence and all of this kind of thing. And I'm seeing that really go away. And everybody's saying, we're midwives, we're one. It doesn't matter where we practice, we are one. And that has been a really, really beautiful thing.
It does. So, it sounds so beautiful.
Yeah.
I'm so happy to hear that.
I think also, like, I should say that, like, I am a person that already has an army holding me up. There are certain self-care things that I have in my life that are non-negotiable unless I'm at a birth. So those things are, you guys probably, if you follow me, I take Pilates 3 times a week. Hi, Kristen, if you're watching. I'll see you tomorrow at 9. So I take Pilates and I really love it. I'm totally one of those people. And it was really life-changing for me to do that. So I don't sacrifice that. I in therapy, I have group meetings with certain like people that I'm connected to who, like, spiritually we support each other spiritually and in business and things like that. And I have not let any of that fall by the wayside. I really do need a haircut. That's not really happening.
I think I do too. Oh gosh.
Very crazy. I'm seeing it now. Like, oh my God.
No.
Whatever. So
it's a new look. I think it's called the pandemic look.
It's called pandemic. I just talked to a client today and I was like, so how's your diet? She's like, it's COVID. So that's like baked goods. That's like a lot of chocolate chip cookies and like
way too much.
And
way
like
too much eating
with your kids. Exactly.
Yes.
So,
I love it.
So that has been really, really nice. And I think that the other thing for me that I don't know if it's really self-care, but it feels really good. I feel super blessed to be an independent midwife. Meaning
gratitude is a great self-care activity, but tell us why.
I don't work for anybody. Like what happens in my practice, or, you know, I have a partner, Robina, that I work with. What happens in our practice is between us and the client and God. You know what I mean?
Yeah.
Like
Yeah.
we don't have admitting privileges anywhere. We don't owe anybody anything. We can just tell people the truth, and we can just speak directly to our clients and protect them any way we need to. And furthermore, when the newspaper calls and wants to talk to me, I can speak freely. And I am.
Good.
And that feels really good to have like a big amplified voice for people that need one and have been convinced that they shouldn't use it. I mean, I don't think anybody in this town should accept those policies where their partners aren't allowed. It's unacceptable, and it's not going to help. It's not going to stop the spread of the virus at all.
No. They live together. Like, he's not exposing.
Maybe together, maybe.
And he's not exposing her. She's not exposing him. And together, they don't represent a bigger threat than singly because they live together. It's insane. Yeah. Okay. Yep. So
I don't
same
know.
Way.
I mean, it's interesting because, I mean, you know better than me from a public health perspective because that's your thing. But you probably have the words for this. You're smart. But I feel like, I don't know, like, unless there's some sort of public takeover, I don't know how there's going to be money for there to be institutions for people to birth in that are not hospitals, because that's where the big money is in those hospitals.
Well, it's not in the hospitals, it's in the insurance. And unfortunately, the insurance and the hospitals are in bed together. So that's why it looks like it's in the hospitals. It could change very rapidly if insurance companies and Medicaid added midwives and birth centers as standard payer types that are sustainable wages. Many states have added midwives to being able to bill Medicaid, but they don't reimburse a sustainable wage.
Right, like
$1,100.
Like $700 or something like that.
Yeah, right. In some states it's $700. Some states it's $1,100. Some places $1,500. But that price for 9 months of care and a 12 to 24-hour labor and 3 or 4 postpartum visits is not sustainable.
And travel and your staff, like no facility fee. So
it's insane.
And your equipment and your malpractice insurance, you get nothing.
Nothing. No, you actually pay to take care of those clients. So when that's the case, midwives can't take Medicaid, and then we have 50% of the population that has a service they can't access. So as long as that system continues, you're right, it will have to be the places with deep pockets to provide this solution. The problem is that the places with deep pockets do not embrace or understand this model of care. So anything that they create ends up being a mini hospital or mini obstetrics care offered without hospital backup, which is actually the most dangerous form of maternity care. If you're going to do all the things, you have to have all the things. If you're not going to do all the things, you can't be outside of a hospital environment. So that's a very dangerous combo. So basically, we come back to the reality that the entire healthcare system has to be overhauled. The entire insurance system has to be overhauled. And this is why I have maintained for years now that we're 15 or 20 years away from that kind of shift. This crisis might speed that timeline up, but not if we use the techniques and the tools that we currently have. We have to literally reinvent it. Because I agree with you. I think that it won't shift on a mainstream level until the payer system shifts.
Yeah. And I think that like that has to come from many places, but ultimately it's going to have to come from the consumer demanding it and saying, no, we're not buying into this anymore. This is not helping us. This is not good for us. And it's not giving us the best possible outcomes.
Well, I think it's twofold. I mean, consumer demand, yes, that definitely has to be a major part of that. We saw the spike in 2007 when The Business of Being Born was published. Whoop, it was the same sort of thing. Every one of us got like double the calls we ever used to get, every one of us in practice. And statistically, that's when we went from like almost negligible numbers to doubling in just a span of 11 years or something. The home birth rate in the United States doubled in that time frame. This will also create demand that really cannot quite be met. Like you were saying before this even started, you were basically full. And some people, policymakers, are really seeing the writing on the wall. Like, for instance, the mom's bill that just moved through Congress, is moving through Congress, that earmarks $15 million towards the support of education of midwives, creating more schools and creating more scholarships for midwives of color and da da da. If this really is successful, I've heard there's already been 3 or 4 applications for this money. I believe Meek is one of the administrators of this money. ACNM also gets to direct some money, or ACMB, or however the IBM, I can't remember the acronym for the education part of ACNM. Anyway, if that really moves forward, we might start to see some turnover, but there's like 10,000 CNMs, right?
Oh.
Yeah, I think there's 10,000 CNMs and there's about 2,000 CPMs.
Yeah, and there's like,
in
I
the
don't know,
whole
20
country.
CMs.
Yeah, and there's only 6 states where it's legal to be a CM. I think there's more than 20,
well, New York
but
is
it's
one of them. New York
is one of them. It's not that many, and yeah, I think overall we need about 20 times that many midwives in the country.
Yes.
So, a few schools adding a few scholarships is not going to change this. One more school graduating 12 people a year, it's not going to change this. Like, we really seriously need a massive overhaul. Yeah, I mean, as much as I know. And consumer demand is a big part of it. But money is the biggest part of it in the US. Where the money comes from, who decides where the money comes from, where the money goes. Follow the money, So we'll see what happens. But in the meantime, please take good care of yourself, my sweet, sweet friend. I love to hear your boundary setting and your clarity about not overextending yourself. That makes me so happy. Please continue to teach that. I want to circle back. Somebody did ask if you're allowing students to participate in care.
So, my practice is Small Things Grow, and it's with Robina Khalid, and we've been together working as a practice since June of 2019. Well, we were working together before that, but our first babies were born in June. And we decided, that when we first started out, that we weren't going to take students at first because we wanted to get all of our policies and practices, going. And then we would see about it. So I do think that in the future, we will definitely want students. The problem, as I see it, is several problems. One is that home birth midwives never have enough malpractice insurance for any university program to send their people to us. So having a clinical placement in a home birth practice is extremely rare in terms of if you're going the university route, meaning you're going to become a CM or a CNM, you're going to sit for the AMCBs, which if you're planning on practicing in New York, that is what you are going to do. It's the only way you can do it. There is a push for CPMs. Hopefully this will be the thing that makes them, we just need more freaking home birth midwives.
I know,
so that
right?
would be great.
Yeah, that would be great.
But so that's one problem. The other problem is that I contacted a Meek school out of state saying that I wanted to take a student, and they said that they have to pay enormous fees to be able to send a student out of state. And I said, well, that's interesting because I went to Yale and I did my clinicals in New Jersey, and they said, well, Yale can afford that. So what I'll say is that probably, I mean, they probably can.
They probably can.
I know what I paid for that. It was a lot. Anybody is here from Yale, they know what I'm talking about. So what I will say is what happens to people that are in New York City or who want to practice here, either you're part of PEP, which you would know better than I do, which the portfolio evaluation process is kind of going away, isn't it?
No, it will never go away. What's happening is that states are no longer accepting it. So it will go away the way of the dodo by virtue of the state licensing programs that are pushed across the country, but not because NARM is disappearing it. So there are still 33 states where you can have a PEP earned CPM in practice.
Okay. So, so anybody who is pursuing that, that would be a reasonable person to try to come to New York City. I know there are probably many practices that would like students in that way.
Yeah.
And then what I think most people who become home birth midwives in New York do is they go to university, they get their training, they get their CNM or
But
their
do you know
CM.
if there are students attending births like right now as a result of the COVID exposure?
Oh, is that the question?
Yeah.
No.
No.
Not that I know of in New York City. Right now, all the clinicals have been canceled. So no students have been coming. So anybody who's in university who goes to the hospital to do their clinicals, whatever, like it's not happening.
Yeah.
Everything's
That's what I wondered.
Yeah.
Yeah, that's what I seen. And I just saw a comment on one of our posters just a little bit ago that said that the hospitals have also freezed all the hiring of new students or new graduates.
Oh, well, that's interesting because Governor Cuomo just sent me a letter saying that if I was a former healthcare worker or a retired healthcare worker, they'd like to have me back.
Yeah.
So they're trying to get people to come out of retirement to work.
Yeah.
It's interesting that they won't take new grads. I mean, they should.
I would say they're actually, yeah. Well, anyway, that's a policy decision that does not involve us, so we don't have to do that. My dear, it's been such a pleasure to see your smiling face and hear your wisdom again. Thank you, thank you, thank you. And keep taking good care of yourself. I love you.
I love you
Bye,
too,
honey.
Augustine. Thanks for having me. Bye, everybody.